Yes,
Hello.
sir. Visible.
Am I audible?
Yes, sir.
Yes, sir.
Yes.
Audible. Audible.
So we are going to talk about a very important emergency in the emergency ED room. That is
Sir,
status. Yes.
little bit in between. Your voice is in between, not very clear, sir.
Okay.
Hello.
Can you hear me?
Yes, sir. Yes, sir.
Okay. So this is one of the most common emergency room condition which we come across day-to-day life. This is common for the pediatricians in office. It is as common to the PG students who are managing in the ED and also in the intensive care. So this is, I think we should be well versed with the management of status epilepticus, and we are going to focus on the first hour management, as the name says, ED management. So let's start with this illustrative case of a 3-year-old child who is brought by worried parents to the emergency department with fever and first episode of generalized convulsions. He is maintaining the airway, but his breathing is irregular and saturation is 88% on room air. His peripheries are warm, CRT is 2 seconds, he is presently convulsing. So looking at his primary assessment, you know that this, though his airway is secure, he has breathing issues, so he has respiratory distress and perfusion looks normal. So probably he has a neurogenic or respiratory distress because of neurological cause, because he is presently converging. So now the next question is this a febrile convulsion which has led to this, or is this status epilepticus, or am I dealing with fever triggered epilepsy first episode? Now, does this, all these questions, are they important at this stage? No, because at this stage I am not concerned what is the cause of this convulsion. What I am concerned is whether this is status and whether I need to stop it immediately. So the treatment strategy or the priority at this stage are, does not depend upon the underlying etiology. The message is very clear. In a golden hour management or the initial management, it is the stabilization and control of seizures which take precedence over etiological diagnosis. So let's move on. Now, conventionally, status epilepticus was defined as a seizure lasting for more than 30 minutes, or any seizure which keeps recurring without regaining consciousness for more than 30 minutes. But this is not a new definition, or this is not how we now look at status epilepticus, and there are reasons. We'll discuss those, why this is now considered as an old definition. What is important in status epilepticus? Why we are discussing the duration of seizure? Now, there are two important aspects which we need to look at. First, of course, is the long-term impact. As the seizures keep on prolonging, we know that there will be a neurological damage and the child would have morbidity or mortality. So we are always worried about this neuronal damage or irreversible neurological damage. And second thing is, what we are worried is, of course, the immediate impact of seizure on the hemodynamics, or immediate impact on the life or the mortality of the child. So these are two important time points which we consider. One which may affect the immediate hemodynamics of a child, airway, breathing and circulation, and second, the irreversible neurological damage. So the earlier definition of 30 minutes was focusing on the second aspect, that is how long the seizure would continue and would lead to neuronal damage. But we have understood with various experiments that it is very difficult to say whether it is 15 minutes, 20 minutes or 30 minutes, and we are not sure. And as the knowledge advances, we now know that even 10 minutes or 15 minutes can also cause irreversible damage. So for the time being, we are not sure about the duration on that aspect. But definitely know that if seizures continue beyond few minutes, it is going to cause respiratory compromise, it is going to cause hemodynamic compromise, and therefore there is no point in just talking about neuronal damage, but it is also important to stop the seizure from a respiratory or hemodynamic point of view. And therefore, right now, for a useful definition based on mechanism of seizure leading to neuronal damage is not feasible, and therefore we focus on an operational definition of seizure, which is now defined as any seizure which is 5 minutes of more of continuous clinical or electrographical seizure activity, or any child who has seizures which are recurrent and has not gained consciousness within 5 minutes. So this is known as an operational definition of status epilepticus. And I would go further and say any child who comes to you in the office convulsing is taken as status epilepticus now. And I have explained to you why we have now shifted from 30 minutes to 5 minutes. Now, for a theoretical definition, yes, established status epilepticus still remains as 30 minutes. So any child keeps convulsing or does not regain consciousness with recurrent seizures of 30 minutes, and of course he has not definitely responded to benzodiazepines, is established status epilepticus. Then what is refractory status epilepticus? Child who has not responded to your two classes of anti-epileptics and he is still convulsing after 60 minutes is a refractory status epilepticus. That includes your benzodiazepine 2 doses and second line therapy in the form of either phenytoin, levetiracetam or valproate, any of those. So two classes, not two doses of chlorazepam, two classes of drugs you have given and the child is still convulsing is a refractory status epilepticus. And these are from Neurocritical Care Society Status Epilepticus Guidelines 2012. Now, we know that there are various types of seizures or epilepsy, and similarly, all of them can lead to continuous status or continuous seizures, and so therefore you can have generalized status epilepticus, it can be tonic, it can be tonic clinic, it can be absence, even myoclonic for that matter, or it may be partial. In partial, if there is no loss of consciousness, it becomes simple partial. If consciousness is impaired, then it becomes progressive partial. And if consciousness is impaired, then it becomes progressive partial. Uh, 5 to 10 minutes, 5 minutes for generalized, 10 minutes for partial, then they are status epilepticus. That is how we define it. Now, we know that most common type of status epilepticus is generalized status epilepticus or generalized tonic-clonic. Partial complex is the next common, and the commonest etiology of status epilepticus is simple febrile convulsion. So febrile status epilepticus is the most common cause of status epilepticus. Now we know that status epilepticus affects almost 50 to 100 per lakh children, and if you have seizures, if you take seizures in general, so coming to pathophysiology, we will not discuss this busy slide in detail, but again coming back to two important things. One is the long-term damage. Why do we get continuous seizure activity? There is a continuous excitatory neurotransmitter glutamate, so glutamate receptors. So there is an upregulation of this excitatory neurotransmitter glutamate receptors, and there is lack of inhibition of GABA receptors. So these two mechanisms, so there is either continuous excitation or lack of inhibition which will control seizures would lead to status epilepticus. So as these neurotransmitters, they uh, upregulated, you are going to get neuronal damage beyond 15 minutes, as we said, sometimes 20 minutes or 30 minutes. Along with neuronal damage, you are seeing a lot of physiological changes. They are a part of compensatory mechanism, which I'm going to discuss in the later slide. And the compensatory mechanism includes a lot of catecholamine release, which leads to your tachycardia, arrhythmias, hypertension, pupillary dilatation, and hyperthermia. They are also because of continuous motor activity. This also leads to a lot of metabolic problems like hypoglycemia. Obviously, the child is NBM, he is seizing, his oxygen and glucose requirement has gone up. There is a lot of muscle activity leading to rhabdomyolysis, myoglobinuria, and sometimes renal failure. That also, all these also lead to hyperkalemia. Hypoxemia is because of increased requirement and impaired airway and oxygenation, and there could be hyponatremia. So there are a lot of metabolic problems which also occur simultaneously as a cause or effect. They themselves can lead to seizure, or the seizure can occur because, or they can seizure themselves can lead to metabolic problems. So it's like sometimes metabolic problems can cause status epilepticus, or status epilepticus itself can lead to metabolic problems. Because of catecholamine release, you are going to get autonomic dysfunction. Initially, it is for a good, that is, it's a compensatory mechanism, but later on, it's going to fail. You may have hypotension, shock, and raised ICP. So that's the pathophysiology. In the brain, you have raised ICP. In the periphery, you have compromised respiration. You have poor perfusion, and you have a lot of metabolic problems happening simultaneously. So it's a multi-systemic involvement. It's not just neurological involvement. So coming to duration, so all these changes would be temporary if you can avoid seizures early. But as the seizures prolong, the systemic changes go on and they can cause life-threatening problems, life-threatening airway obstruction, respiratory arrest, significant hypotension, metabolic problems, and all of them can lead to mortality. So there is a morbidity element, but what we are worried in the emergency room always, in the emergency room, our main goal always is to prevent mortality. Of course, we need to have an intact survival. So morbidity also is crucial. So that is the reason why we are discussing duration of seizures. So I think the message is clear. Abort seizure early. Longer the seizure lasts, longer it will be getting difficult to control, and the more would be the damage, either in the form of mortality or morbidity. So, what is the physiology behind the pathology which we have just seen? So let's look at this. We know that there is a motor activity, therefore the brain needs more oxygen, and because brain needs more oxygen, you need to supply that oxygen to the brain. To do that, there is a cerebral autoregulation which tries to maintain the blood flow, and therefore your cerebral perfusion pressure is maintained. This happens by increasing the MAP, that is mean arterial pressure, so that your cerebral perfusion and the blood flow is maintained, oxygen requirements are met. And how does this happen? This happens through catecholamine surge or autonomic discharge. Now, any compensatory mechanism has its own limitations. Beyond certain point, your ICP, the blood flow has increased so much, the ICP has gone up so much that your cerebral perfusion pressure starts dropping, because we know that cerebral perfusion pressure is equal to MAP minus ICP. So if your ICP has gone beyond 20, gradually your cerebral perfusion pressure and the blood flow will drop, and also at the same time your catecholamines have stores have exhausted and the blood pressure is started falling systemically, and even the cerebral perfusion pressure is dropping. So this is your exhaustion phase. So if you put it on the timeline at the 0 minute, you have catecholamine discharge. This will maintain your oxygenation. Simultaneously, side effects are going to occur like hypertension, tachycardia, high CVP. But what we are gaining is we are maintaining the oxygen requirement of the brain. But as we go to the next phase at around 30 to 60 minutes, we know that the compensation has the body, the decompensation has start occurring. Your stores are exhausted. Your blood pressure is now dropping. Oxygen is not going to be met with, and you are going to, in the brain, you are going to gain hypoxic ischemic damage, that is your permanent neuronal damage. In the periphery, you are going to get hypotension, hypoperfusion, because the state of decompensation has occurred. So the message is we need to catch the child somewhere here. And again, the same important message, catch them early, start treatment early, and abort seizure very aggressively. I hope this is an important slide which is very, very clear to you. Let's move on to the goal of management of status epilepticus. Of course, ABC we have been, I think, must be talking since morning. So that is the first aim of resuscitation, A, B, C, and D. You need to stop and prevent further seizures. Of course, etiology is crucial, but these two take precedence in the first 15 minutes. Investigate the child and treat the cause. Hypoglycemia should be investigated very early during ABCD. And then, of course, as we said, the secondary damage or the primary problem is seizure, but secondary damage because of seizures need to be prevented and treated. Let's look at seizure control in this talk. So, how do we control seizures? As we said, emphasizes a more aggressive clinical approach by rapidly initiating first line therapy, that is benzodiazepines, and then accelerate to second line therapy, that is your phenytoin or lovastatin or valproate. And one more important concept is you need to consider non-convulsive status epilepticus more often. It is not recognized many times because that will lead to continuous seizure activity and pathophysiological damage, which we have already discussed. So, anti-epileptic drugs, we simultaneously need to take care of A, B, C, D, E apart from anti-epileptic. Epileptic are important, but only continuing or continuing our efforts to stop seizure is not going to work. Simultaneously, we need to take care of airway, breathing, circulation, and disability. And even if there are other precipitating features like fever and other factors which must be considered. Now, coming to some of the drugs, I think we'll go through the pharmacology of few anti-epileptics. Uh, First and foremost, the first initial line of therapy or first line therapy is benzodiazepines, and lorazepam we use in the dose of 0.05 to zero point 0.1 milligram per kilogram. Maximum dose is 4 milligram. It should be given over 2 minutes. You can use IV, intraosseous. It can be even given per rectally or intrabuccal in the same dose. Another benzodiazepine which is available is diazepam, which is zero point 0.1 to zero point 0.3 milligram per kilogram. It is given over 2 minutes. It should be diluted in the blood. It should not stay in the tubing. And benzodiazepam. Now, the common question is which is better? Lorazepam has a longer duration of action. It causes less respiratory depression as compared to diazepam, and therefore usually it is a preferred drug. Midazolam has less depression as compared to diazepam. Again, the duration of action is shorter, and advantage, of course, is it can be used by any routes. So there are multiple routes by which midazolam can be used. And the second dose should be repeated after 5 minutes if the seizures do not come under control. Now, the second line treatment is either if the seizure still persists after 2 doses of lorazepam, we need to start phosphonatoin, phenytoin, or levetiracetam. Phosphonatoin is, or phenytoin, I will start with phenytoin, which is the oldest drug, 20 to 30 milligram per kilogram, should be given over 20 to 30 minutes. We have a better form of, it's a pro-drug phosphonatoin, which is available, which is 20 to 30 milligram of phenytoin equivalent, that is 1.5 times the dose of phenytoin. The advantage of phosphonatoin is it can be given fast. It can be given over 5 to 10 minutes. It can be given IM sometimes. It can be diluted with any type of fluid. It can be diluted with dextrose, normal saline. Phenytoin has to be diluted in normal saline. And there are less cardiac effects, side effects as compared to phenytoin. Therefore, phosphonatoin is preferred in many centers. But if you don't, it's not available, you can use phenytoin, but should be given slowly. Now, in seizure control, time is crucial. Therefore, that phosphonatoin, which can be given in 5 minutes, is a major advantage. And remember, I think this is a common mistake which is done by even postgraduate students. It should not be given over 20 minutes or 30 minutes. Just push it rapidly over 5 minutes. And many times the drip is going on for half an hour and the child is converting. That's not, you are not doing the right way. Third drug which can be used with levetiracetam, which is 30 milligram per kilogram loading dose. Now, usually the earlier thinking was phenytoin and phosphonatoin, levetiracetam is now added, can be the additional alternative drug. So it depends on the local institutional protocol. We in our institute use phosphonatoin as the first drug and then levetiracetam as an add-on. But either of them are okay. Now, phenobarbital, so third drug. So we have given benzodiazepine, we have given either of the second line drug, the child is still seizing or still convulsing, we need to give them phenobarbital if the seizures have persisted after your second line drug. And the dose is 20 milligram per kilogram IV, again can be given over 5 to 10 minutes. It causes respiratory depression and hypotension, particularly if given with benzodiazepine. So you need to be ready once you have reached this stage to take care of airway, and sometimes even electively you need to ventilate if the child's GCS is low and the child is still convulsing. So this is the next step which you will do.
Sir,
Yes.
your voice is breaking in between, sir. Your voice is breaking in between. Okay. Could you directly speak to the laptop itself, sir? Your voice is breaking in between.
Am I audible better?
Now only, sir. Okay, in between there was a break. Now audible, sir. Can you speak once more, sir?
Hello. So be sure to be ready with airway control, particularly
Yes, sir. Yes, sir.
if the patient is in refractory status epilepticus. Am I audible better?
Yes, sir. Yes, sir.
Okay, so I will not use earplug then. Is it better?
Yeah, yes, it's better now, sir.
Okay, okay. Okay. So now coming to lorazepam, please let me know if there is any problem. So coming to lorazepam, benzodiazepine, this is the benzodiazepine of choice because it is fast acting and there is a longer duration of action. And again, remember to give it within 2 minutes, or it should be given over 2 minutes, not very slow. The dose we have already discussed, you can repeat second dose after 5 minutes, and the maximum dose is 4 milligram. This drug has to be stored in the refrigerator. Remember this. So what are the advantages? It has longer duration, less respiratory depression, and also it can be used in a sublingual way. And therefore, lorazepam scores over diazepam, and it is usually the drug of first choice. Diazepam, most commonly used in the peripheral setup in all types of status epilepticus. Action again within 2 to 3 minutes, but duration is only for 5 to 10 minutes. It should not be given into the tubing, directly into the vein, and the dose is 0.1 to 0.3 milligram, slowly over 2 minutes. Maximum dose is 10 milligram. You can give 2 doses. Other route which can be used is intraosseous, When you are using rectal dose, it should be 0.5 milligram per kilogram. Coming to midazolam, as I said, it can be given intramuscular, intranasal, buccal, sublingual, or even per rectal, and therefore it becomes a drug of choice in the out of hospital situation, particularly in the clinic situation. Midazolam may be a drug of choice because it can be given IM, and intranasal spray is also available now. Second thing is, it is also used as an as a coma induction therapy. We'll come to that in a minute. The dose for loading is 0.05 to zero point 0.1 milligram. For an IM dose, it is 0.2 milligram. The nasal spray which is available is 0.2 milligram per kilogram, and it is available as 1.25 milligram of midazolam per spray. The dose is 0.5 milligram in each spray which is available, and the dose is 0.2 milligram per kilogram. So if you have a 10 kg old child, we'll have to give 4 sprays. Coming to phenytoin, uh, it is useful in generalized tonic-clonic seizure. The dose we have already discussed. Maximum is 1 gram, and it has to be given over 20 to 30 minutes. It should be dissolved only in saline because of the alkaline pH, and it can cause phlebitis. If seizures do not recur, you start with maintenance dose, which is 3 to 9 milligram divided in 2 doses. You start the maintenance after 12 hours. We have discussed this usefulness of fosphenytoin already. Less tissue damage, it has less phlebitis, and it can be diluted with any fluid. Coming to levetiracetam, refractory status epilepticus sometimes is associated with liver failure, coagulopathy, and hypotension. So advantage of levetiracetam is you can use it even if there is liver dysfunction, because it is not metabolized by liver and it is excreted by kidney. And there are limited drug interactions, so it's a safe drug, does not cause respiratory depression. So in a peripheral setup, is a useful drug, and it can, if facilities are not available, you can add it or use it along with fosphenytoin, and it can help you to prevent intubation or buy some time. So coming to phenobarbital, which is given first in some centers, or already if the patient is on phenytoin, because of the respiratory depression or long-term effect, some centers do not prefer it. The loading dose is 20 to 30, maximum dose is 1 gram, and it is given over 5 to 10 minutes. Side effects are respiratory depression and hypotension. So coming to definitions of refractory. So we have already said what is status epilepticus. What is refractory status epilepticus? Seizures which persist despite the administration of 2 appropriate anticonvulsants at acceptable doses, and usually by this time the duration of seizure would have already crossed 60 minutes. So 2 appropriate anticonvulsants, I mean 2 classes. You have given 2 doses of lorazepam and either fosphenytoin, phenytoin, or levetiracetam, or some centers also use valproate. So if you have given these 2 drugs and seizures have not been controlled, 60 minutes I am sure would have been passed. It's a refractory status epilepticus. There is another terminology which is used, is super refractory status. It is a status epilepticus that continues 24 hours or more after the onset of anesthesia. So if seizures have not been controlled after your phenobarbital, your next step is to start midazolam drip or thiopentone or propofol drip. So if after starting this seizures continue to occur 24 hours or more, then or they recur, keep recurring within 24 hours or more after reduction or withdrawal of anesthesia, then this is a super refractory status. So any seizure which continues 24 hours or more after anesthesia is a super refractory SE. So in a super refractory status epilepticus, the child would be on multiple anticonvulsants. First, of course, we have started this child on benzodiazepine. Second drug which we have given is fosphenytoin or levetiracetam. And the third drug which we have given is phenobarbital. The seizures have continued, so we have already started him on the child on midazolam drip, and the other drugs like propofol or thiopentone can be add-on, or you can start them instead of midazolam. Most of the centers would start midazolam as the first line therapy, and then add-on propofol or thiopentone is given. In addition to that, lacosamide and topiramate also have usually are started at this stage. So the child, as you can see, is almost on multiple 6 to 8 anticonvulsant by the time the child is goes into refractory or super refractory AC. Another drug which I think is becoming popular is valproic acid IV for second line therapy instead of fosphenytoin. It is given in 30 to 35 milligram per kilogram, again over 5 to 10 minutes. When do we really use valproate? Particularly when your benzodiazepine, already the child is in hypotension, you don't want to use benzodiazepine, you don't want to use midazolam. So there is a known sensitivity of phenytoin, then instead of fosphenytoin or phenytoin, you use valproate. Or already the child was on valproate and he has missed many doses and come back to you with seizures, you can load him with valproic acid. A word of caution, of course, it is a hepatotoxic drug, so you should be cautious in using this child in infants, particularly those children who have hepatic and metabolic diseases. You should be careful. So how do you start midazolam infusion? You load these children with the dose of 0.15 milligram per kilogram and usually start an infusion at 2 microgram per kilogram per minute and go on increasing by 1 microgram per kilogram per minute after every 10 to 15 minutes until you get good control of seizures. The maximum dose described is 10. In some textbook even describes up to 20 microgram per kilogram per minute. But obviously it leads to hypotension, so most of these children would be on inotropes by the time they have crossed the dose of 5 microgram per kilogram per minute. Once you have controlled seizures with midazolam, don't stop it immediately. Maintain the same dose for 24 hours. This is an usual mistake. We tend to stop it early. Don't do that. Seizures would recur and again you will have to continue for 24 hours more. So stop. Continue same dose for 24 hours. Then wean by 1 mic every 2 to 3 hours. You need to understand that these things can be done with full-fledged PICU facilities, ideally with continuous or a portable EEG monitoring which is available. It should be available because you need to see burst suppression pattern, and at higher doses your aim is to get burst suppression pattern, and therefore you need to have all these facilities of intubation, ventilation, inotropes and EEG monitoring. Then only you should venture into midazolam infusion. So I think you need to shift the patient in time. Another option or an add-on is thiopentone infusion. The dose is 3 to 5 milligram per kilogram loading dose, and then 1 to 5 milligram per kilogram per hour. You can start with 1 and gradually increase it. This is again an anesthetic drug. By this time, child is already intubated and ventilated. You should have central line IBP because all these drugs are going to cause hypotension, and most of these would need EEG monitoring because there could be a non-convulsive status epilepticus which you need to pick up. Your aim is to get burst suppression pattern. Propofol is another drug usually not recommended in pediatric because of the side effect of propofol infusion syndrome, which is acidosis, rhabdomyolysis, and hemodynamic instability. If you use it is 2 milligram and then 1 to 3 milligram per kilogram. Usually this is not recommended beyond 24 hours. Another drug is pentobarbital, which is not available in India. We have used thiopentone and even ketamine and propofol in some patients. Particularly in neonates who are not responding or seizures are not getting controlled, definitely you need to give pyridoxine 100 milligram. Or in infants with resistant seizures, there is a condition known as B6 responsive seizure, and you need to consider this as an add-on drug. So now we have discussed that we need to start midazolam after phenobarbital, but there is a proponent in 2016 that we should use accelerated protocol. Why so? Because we have been talking about duration of seizure and long-term morbidity or immediate mortality. And as seizures prolong, your GABA receptors get internalized. They are no longer on the surface. Benzodiazepines will not work. Midazolam will not work, and therefore it would refractory status will become super refractory status, and therefore you want to prevent this from SC to going into refractory, refractory to going into super refractory, therefore be aggressive. So when do you use accelerator protocol? Definitely if you have a known epileptic with breakthrough status, if you have underlying injury which is likely to cause further seizures, or if you have facilities for rapid airway and hemodynamic support, then definitely you would go with accelerated protocol. And let's look at this protocol of what we have discussed till now. Any child who comes to you with convulsion in the emergency room, of course, as a pulse trainee, you know that it is ABCDE, and hypoglycemia is one thing which you should not miss. Apart from that, take care of airway, oxygenate, if required, bag mask ventilation, positioning and suctioning. So ABCDE and control of seizure simultaneously. First drug is lorazepam. After 5 minutes, one more dose of lorazepam is what we are going to use. If seizures after 5 minutes are not controlled, then you are going to use phenytoin or levetiracetam. Seizures still continue, 10 minutes have passed. Either you give second dose of phenytoin, because you have given 20 milligram of phenytoin, you can add 10 milligram more, or you can give phenobarbital as the third line drug. Now, if seizures still continue, then this is refractory status, we already know that, and you will start this child. Of course, you will intubate, ventilate much before. Start the child on midazolam infusion, start increasing gradually, reach up to 10 my IV valproate by this time is already probably added in most of these patients, and then you have other options like thiopental propofol, which can be add on to your infusion, and IV pyridoxine we have already said. So in short, it is the first line, second line, third line, and then you have coma induction therapy, which is midazolam, and you would have already given valproate and lacosamide and topiramate by this time. These are other therapies which can be considered. So this is your usual standard protocol which we have discussed. But what we have said is we need to sometimes use an accelerated protocol to prevent morbidity and mortality. What is proposed accelerated protocol? You are given lorazepam, and when you are giving second dose, simultaneously start giving. So a second dose of lorazepam and phenytoin should be given together on two different lines. And then after that, if the seizures persist, instead of phenobarbital, straight away intubate, ventilate, and start coma induction therapy. That is the proposed accelerated protocol. Many centers follow this. Many times we also follow in our center the accelerated protocol. And so if the seizures have not responded to second line therapy, instead of going to phenobarbital, you go straight away to third line or the coma induction therapy. That is the accelerated protocol. We know why we do this. So early intubation and coma. What is non-convulsive status epilepticus? It's an entity which is less familiar, more familiar to the intensivist and the neurologist. This is, there are no motor manifestations. There may be subtle manifestations in the form of eye movements. There may be paranoid movements, behavioral changes, fluctuating level of consciousness, autonomic changes like changes in heart rate and BP, all these are manifestation of non-convulsive status. So there is no frank motor seizures, but you have subtle signs, nystagmus or eye movements, tracking. And why it is important to control? How do you diagnose? You diagnose it by doing continuous EEG monitoring or maybe whatever EEG. Unless you do this, you are not going to diagnose it. And it could be this is the source of continued coma. If the child has been managed well and still child continues to remain with altered sensorium or fluctuating consciousness, think of non-convulsive status, and it could be the cause of coma in some patients. So, friends, and recognition is vital, and only it can be suspected on clinical ground, but diagnosis can only be done by EG. So, friends, take home message from this talk is we have updated the definition of SE to make it more clinically relevant and operationally easy. And this has been as per the 2016 revised protocol. And as we said,